Hello everyone, and thank you for joining me today. My name is Grant Roberts. I'm from the University of Wisconsin-Madison, and today I'll be presenting our abstract titled Free Breathing Radial 2D Phase Contrast MRI for Aortic Pulse Wave Velocity Measurements in Healthy Older Adults. Pulse wave velocity is a clinical biomarker defined as the speed at which a pulse pressure travels through a vessel. So, in essence, as arteries become stiffer, either due to vascular disease or from normal aging, pulse waves are conducted much faster compared to more healthy, elastic arteries. And this is an important clinical biomarker because arterial stiffening is one of the earliest detectable manifestations of vascular remodeling that is caused by cardiovascular disease. And this can occur well before luminal narrowing might be seen on angiography. There have been a number of studies showing associations between increased pulse wave velocity and increased incidence of cardiovascular-related diseases. Most clinical studies assessing pulse wave velocity have utilized applanation tonometry, primarily because it's easy to perform and it's relatively inexpensive. So in this method, pressure waveforms are obtained in either the carotid and femoral arteries or in the brachial and tibial arteries. And the time delay between these pressure waveforms is a function of both vessel distance and vessel stiffness between the heart and these measurement locations. However, one of the biggest problems with tonometry is that vessel distances must be approximated based on patient body type, which has been shown to greatly increase error in pulse wave velocity measurements. 2D phase contrast MRI has been successfully used to determine aortic pulse wave velocity by measuring temporal shifts in flow waveforms between imaging planes. An obvious advantage of this method is that we can calculate vessel distances between planes using a separate anatomical scan. When imaging the aorta, respiratory motion is avoided by performing breath hold exams, which usually last around 15 seconds. However, in certain patient populations, such as elderly, cognitively impaired, hearing impaired, or those with severe respiratory disease, breath holds may be difficult or impossible. So the purpose of this talk is to propose an alternative free breathing methodology using a radial 2D phase contrast sequence. In order to test the feasibility of our free breathing radial sequence, we compared our pulse wave velocity measurements to a standard breath hold Cartesian GE product sequence. And this was performed in 18 middle-aged subjects at 3 Tesla. Scan parameters for both sequences are shown on the right. Note that for the radial sequence, scan times were about 2.5 minutes using 10,000 projections with retrospective cardiac and respiratory gating. And for the breath hold Cartesian exam, scan times were only around 13 seconds using prospective cardiac gating. Scan parameters and resolutions were matched as best as possible for both sequences. And for each sequence, 2 axial planes were prescribed, as shown in the bottom right image, leading to a total of 3 measurement locations, due to the first slice transecting both the ascending and descending aorta. Free breathing VSSFP images were required for aortic centerline tracing, and the exams were about 15 seconds long. The 10,000 projection dataset was retrospectively subsampled to 2,500 projections, corresponding to a scan time of about 37 seconds. This was done to test the effects of undersampling in conjunction with a local low rank reconstruction. Note that the regularization parameter that I used was empirically chosen on the basis of image quality after testing various regularization parameters. For post-processing, a customized user interface was developed in MATLAB, which you can see in the right figure. And this interface allowed for interactive circular ROI selection for the 3 locations of interest. Subsequent flow waveforms were then plotted on the top right panel, and waveforms were smoothed by a Gaussian filter to reduce velocity noise. In this study, we employed various time shift methods, including time to foot, time to upstroke, time to point, and cross-correlation methods, all to calculate time shifts in flow waveforms. Center lines were calculated from the anatomical BSSFP images by manually placing seed points in the aorta over multiple image slices and fitting these points to a 3D B-spline. Lastly, a plot of time shift versus centerline distance was created, and linear regression was used to fit these 3 data points to obtain a final pulse wave velocity, which is the inverse of the fitted slope. So I wanted to share some of the results from the local low rank reconstruction. On the bottom left, we see a velocity image of peak systole for both the fully sampled radial and Cartesian scans. The subsampled radial image without local low rank reconstruction is shown in the top right image, and in the bottom right image we see the results from the local low rank reconstruction. You can see that the overall image quality has greatly improved and is in good subjective agreement with the images on the left. We performed a paired t-test to evaluate if there were significant differences in pulse wave velocity measurements between each acquisition. Results show that there were no significant differences between the subsampled and fully sampled free-breathing radial acquisitions and the breath-hold Cartesian scans. A box plot on the right shows the distribution for each acquisition. Additionally, an F-test was also performed and showed no significant differences in variance between the acquisition groups. A secondary analysis was also performed to investigate pulse wave velocity as a function of age, and our results showed a moderate positive correlation between pulse wave velocity as a function of age, which agrees well with the results from other studies. In summary, our results indicated that pulse wave velocity measures from the free-breathing radial sequence were comparable to that of the breath-hold Cartesian, demonstrating an alternative method for assessing populations that may have breath-hold difficulty. Additionally, I wanted to note that actual exam times for the breath-hold scans were much longer in practice due to the extra time required for patient preparation and recovery, usually lasting around 1 minute. Furthermore, local low rank reconstructions can be used to further reduce scan times or to increase temporal resolutions. Lastly, validation studies using phantom models like the one shown below are needed to compare acquisitions to ground truth pressure wire or ultrasound measurement. I'd like to thank my co-authors and thank you for listening.